Welcome everyone to our latest installment of the Asia Pacific Federation for Clinical Biochemistry and Laboratory Medicine, or APFCB, Masterclass in Interpretive Commenting. So we're super happy and honored today to have as a guest lecturer Associate Professor Ken Sikaris. He is the Director of Chemical Pathology at Melbourne Pathology, Australia, and Associate Professor in the Department of Pathology at Melbourne University. Professor Sikaris has been the chair of the RCPA QAP Chemistry and Key Incident Programs and is an examiner for the AACB and the RCPA Faculty of Science. He has been chair of the IFCC Committee of Analytical Quality and a member of the IFCC Committee on Reference Intervals and Decision Limits. So he's an expert in many things to do with chemical pathology, and we're so happy today to just have him share his thoughts on fertility testing. So Professor Sikaris, please take it away.
Thank you, Perlene. So thank you for, I was looking forward to this talk because I haven't given a talk on fertility for 10 years, even though we get results every day. I should say that I work in a big laboratory, about 15,000 patients a day. So every day we're doing like 2,000 thyroids and 5 or so. And today I'm going to be showing you 20 cases from that selection, but also some data mining, some graphs of all of the results, so you can get a feel for the data. So now I'm not going to go over what Sam told you at the last meeting, but generally when I put an interpretation up, it'll have these 3 elements. What is the abnormality? What does that abnormality mean? And what follow-up might be suggested by that? Okay, now so in this lecture, we're going to be talking about the development of fertility, because that's involved in some disorders of precocious or delayed puberty. Then we'll discuss fertility in men and women, and then we'll have a little bit on menopause, or the end of fertility. The graph here shows that the typical age of men and women having fertility testing. So you can see most patients having fertility testing between about 20 and 50 years of age. So in all of this testing, what we have is the hypothalamus driving the pituitary to produce the gonadotrophins, FSH and LH. And then they stimulate the gonad to develop the egg and to produce hormones such as estradiol and progesterone. And those hormones feed back to inhibit the other. So this feedback mechanism is the crux of interpreting fertility testing. And it's the same with men, FSH and LH. FSH stimulates spermatogenesis, LH stimulates the Leydig cells to produce testosterone. So when we're looking at these hormones, we have the hormones from the hypothalamus and pituitary driving the gonad to produce the steroid hormones, which feed back. So in primary infertility, what happens is that the gonad's not working, primary infertility, and so the hormones aren't feeding back, and therefore you get massive increases in the gonadotrophins. That's the other type is when the problem is centrally in the hypothalamus or pituitary and you're not getting the gonadotrophins. Therefore, the gonads don't bother making their steroid hormones. So that's secondary infertility. So the big difference is not so much the low steroid hormones, but the fact that FSH and LH is high in primary infertility and they're low in secondary infertility. Just some things to remember. All of the pituitary hormones are related by the peptide hormones, alpha and beta subunits, and there's quite a homology between some of them, and they have some cross reactivity. Okay, so our first case is one of a twin, a boy, with ambiguous genitalia, and the sample was taken on day 0, on his birth date. And they did these tests and they got an LH level, which is lowish, and a testosterone level, which seems high compared to whatever this cutoff is, 6.1 for nanomole per litre. So what does that mean? Why should a neonate have a high testosterone? The comment I would say is the elevated testosterone can be seen in the newborn and repeat after 1 week if clinically indicated. So hormones are acting not only through life, but also through the embryo and at birth. And so typically what happens to LH, FSH and testosterone is that they're high in embryonic development and they're quite high at birth. And so LH, FSH and the testosterone are higher in the first week of life compared to later in childhood. And that's a trap for the unwary. They're high because in the embryo and in the newborn, AMH and testosterone are progressing this development of the primitive reproductive tract to become the female or the male tract. And particularly this anti-Müllerian hormone stops the development of the fallopian tubes and uterus and so on. So AMH levels and testosterone levels are high in utero in boys, and they are slightly high also at birth. So here's another boy. He's 5 years old, and he's had a lesion taken out of his testes. There was a lump in his testes that the mother noticed, and it was taken out. It was a granuloma. It was some dead tissue. And the histology, they weren't sure whether that dead tissue was tumour or normal testes that had become ischemic. So they did these tests. Now the estradiol and testosterone were low, as they should be in a 5-year-old. The sex hormone binding globulin was a little bit high, which is probably normal. But the anti-Müllerian hormone was very high. Now, what is the normal range for anti-Müllerian hormone in a 5-year-old? For those of you that know anti-Müllerian hormone in women, levels are normally 50 or 100. But remember, they're much higher in boys. And so my comment on this report is it's a normal level. There's no hormonal evidence of testicular disease in terms of the testosterone, except we're not sure whether there might still be a teratoma there. So if they did want to check the alpha fetoprotein HCG, we could do that for them. So here are the AMH levels in young boys, and they're like 50 times higher than they are in young girls. And so, what I'm saying here is it's vital to understand normal physiology if you're going to interpret these levels. So the children are growing older, and at puberty, we stage puberty by the Tanner stages. And the Tanner stages in boys are a mixture of how much pubic hair there is and what is the volume of the testes. Those are the two ways to measure the Tanner stages. In girls, it's to do with the breast buds and how big they are, and again, how much pubic hair there is. And you can create a Tanner stage for children. Girls go through the age of 9 to about the age of 14. And those various Tanner stages, whether it's the breast or pubic hair, occur at slightly different ages for each girl. So what we were going to talk about is premature or precocious puberty, which is defined as pubertal onset before the age of 8 in girls or before the age of 9 in boys, or delayed puberty, which is after the age of 13 in girls or after the age of 14 in boys. Now, here are the FSH levels. This is some of the data mining. This is a few thousand children that we've measured over the last 10 years. This is Roche, if you're interested in the method. But so FSH levels are usually low. And around the age of 8 in boys, they start to rise. And by the age of 14, they're constantly elevated. So precocious puberty is puberty that's occurred before anyone else has, or before the general population has started to rise. You're already pubertal. That's precocious. Whereas delayed puberty is you're not pubertal even though everyone's already there. So you can see from the hormones that what the basis of that definition. Now, girls develop earlier than boys, and so the definition, if a girl's 7, they're called precocious puberty. And if a boy's 13, if a girl's over 13, it's called delayed puberty. And again, you can see a girl should have been developing by about the age of 8. And so earlier than that is too early. And they should have finished developing by about the age of 13. So if they haven't, well, then there's something delaying that compared to the norm. LH shows it even more drastically. So LH levels, this is on a log scale, but you can see that LH levels climb between about the age of 8 and 14, and they should be at the adult level by about the age of 13 in boys and 14 in girls. So if we were going to judge precocious puberty, the early puberty at the first thing, the tests that are recommended are bone age, just to see whether the child's just aging generally rather than hormonally, and then to measure the FSH and LH to see if they're rising, and then also to see if the testosterone or estrogen are rising. The causes typically, depending on whether it's peripheral, so peripheral means there's something with the gonad in terms of overproduction of the steroid hormone and not driven centrally by FSH and LH. The most common cause is congenital adrenal hyperplasia. Or if it's central, so the problem is there's an overproduction of FSH and LH centrally, which may be due to idiopathic, that means we don't know, it just seems to be that person. Or it may be due to a tumour that's producing LH and FSH or stimulating the production. So here's her first case, a 6-year-old girl. Now she's got pubarchy, so she's got pubic hair at age 6. And so when we look at her results, well, it does look like the gonads are active and it's not being driven centrally by FSH and LH. But when we look more closely at what it is that's elevated, it's not so much the estradiol, but much more the testosterone, free testosterone, and the DHEA. And to cut a long story short, they also did another test, which was 17-hydroxyprogesterone. So this profile here is that very common cause of a peripheral precocious puberty of congenital adrenal hyperplasia. So marked increase in 17-hydroxyprogesterone and DHEA indicates congenital adrenal hyperplasia. And the way you can confirm that is either through a urine steroid profile, which will show the blockage, or a genetic testing. And so in congenital adrenal hyperplasia, you should be familiar with this production cascade for steroid hormone. So the blockage could be at any of those levels. And a urine steroid profile or genetic testing will tell us where the blockage is. So here is this girl with her DHEA level right off the scale. Now DHEA is not coming from the ovary, it's coming from adrenal. This is adrenal disease causing precocious puberty or precocious pubarchy. So these are the levels we should have done, and we did for that girl. But we also should remember that there's other things that can affect puberty, including thyroid hormones and prolactin and so on. Okay, so here's another case. So this is a 7-year-old girl, so she's still a bit young to be having breast bud development, and she's got increased FSH and LH. So this is a centrally driven precocious puberty. She's got an adult level of estradiol and really pubertal or adult levels of FSH and LH. So the pubertal levels of LH and FSH and E2 indicates central precocious puberty. And I think that, I mean, here it's a pediatric medicine, so we don't need to say what the possibilities are. But the most likely thing is that idiopathic cause of or early precocious puberty, centrally driven, which we'll never find the reason for. And here's that girl's results, just to show you how abnormal they are. The FSH, the LH, and the estradiol. Lastly, here's another 6-year-old girl. She's got breast bud development, and it seems to be peripherally driven. There's no central drive. and the estradiol level is 1,600, which is way above what you'd expect even in a pubertal girl. So be the normal FSH and LH for age, but extreme elevation of estradiol. Often it's not necessary to comment on whether something's elevated or not, but here we want to give the practitioner, the GP here, a feel for how abnormal this level is. This is not elevated, this is extreme elevation. And so here we're actually worried about a tumour, either an adrenal or an ovarian tumour. And so we've subtly suggested that because a urine steroid profile can show abnormal steroid production, and imaging of the adrenal or the ovary may show the tumour. What about delayed puberty? So by the time you're age 13 or 14, you should have gone beyond this stage of pubertal development. You may not have any pubic hair. If you don't have any pubic hair and there's virtually no breast development, that's unusual. So what you want to work out whether this is just a general aging thing or an issue regarding a delay in gonadal aging. Now, in a review of what causes that delayed puberty, the most common cause, a bit like idiopathic central precocious puberty, the most common cause is what we call constitutional delay. So they've just delayed. They will eventually become pubertal, but they're slower than everyone else. The next most common is the functional hypogonadotrophin hypogonadism. So that means the low FSH-LH and low testosterone. Functional. So that means it's transient. It's due to things like stress and illness and so on. Compared to permanent, which means there's a permanent problem with the central drive. And then the other type is a permanent hypergonadotrophin hypogonadism. So, the constitutional delay, very common in boys, and about a third of girls, and then the others account for the rest. So we'll try to look. Now, some of those causes, remember that functional delays due to stress or illness, so hypogonadotrophic hypogonadism due to chronic illness, constitutional delay, but then there are some genetic causes, genetic central causes. So if you don't have a pituitary that's working, or you've got a tumour that's knocked it out, or hypergonadotrophic hypogonadism, where there's a problem with the gonad, so that it's been damaged by surgery or radiation, or there's a genetic abnormality and they just don't work in Klinefelters in boys and Turners in girls. So here's a 20-year-old girl who hasn't had a period yet, primary amenorrhea. The FSH and LH are very high. The estradiol's low, progesterone's low. I haven't given you the reference intervals here. The SHBG is low as well. So this suggests hypergonadotrophic hypogonadism. Consider imaging and genetic testing. So it could be a problem, the brain, or it could be a genetic problem. Now, that's just an introduction to this. Here's another case. This one's got primary amenorrhea, and that word that you can't see in this 19-year-old girl is anorexia. So what we probably expect is this functional hypogonadotrophic hypogonadism. So the comment would be normal FSH and LH, but low estradiol suggestive of hypogonadotrophic hypogonadism, which is often seen in anorexia nervosa. We try not to write it on the report. Okay, so the investigation of primary amenorrhea is very much like, so you're interested in whether there's problems centrally or peripherally, and you're interested in whether there's a genetic problem. And the same thing happens with secondary amenorrhea. We're interested in the FSH, LH, and so on. So here's a 20-year-old who has had a period, but they've stopped. And if we look at her hormone levels, which have been repeated over the whole year, very high gonadotrophins, very low estradiol. So this is not a genetic problem. This is an acquired problem because she did have some periods. And so marked elevation of LH with low estradiol, consistent with primary ovarian failure. Now, typically, when it's an acquired early menopause, really, they're anti-ovarian antibodies. But in young people, we should also suggest anti-nuclear antibodies because there's a special type of speckled anti-nuclear antibody which makes this very premature ovarian failure more likely. So it's not enough to do the anti-ovarian antibodies. You still need to do the anti-nuclear antibodies. And here we can see that the low AMH, which we'll talk about, low AMH means there's no eggs left in her ovary. And the ANA was a high titer of this speckled pattern, and there was a negative ovarian antibody. So she's, it can occur at young ages, and it's the biggest fear when you get secondary amenorrhea. So what about investigating adults? So if what is a fertility problem? A fertility problem is if you haven't conceived after 1 year of trying. And testing should be offered to that lady and her partner. So 12 months of infertility. The initial test for men is semen analysis. The initial test for women is day 21 progesterone. And so if the semen analysis is abnormal, then you can do other tests. If the day 21 progesterone is abnormal, then you can proceed to other tests. That's the formal way to do this. Now, typically the problems can be in the man, can be in the woman, or can be unknown. So you have to investigate both the partners. In the men, it's generally testing semen, but also testing FSH levels. These slides will be available to you, so I don't expect you to be able to read them all, but I thought that'd be good to have as a resource. And then for women, really the hormone levels. There are mechanical causes of infertility, but we don't do that in the path lab. They do it in the imaging labs with imaging of the fallopian tubes. So first of all, in a man, if the sperm count is low, like it should be 1 million, but if it's it should be 10 million. If it's between 5 and 10 million, it's lowish. Then you're trying to work out what type of hypogonadism do they have. Is it primary and the pituitary is trying to wake it up? Is it central because there's no drive for FSH or LH? Or is everything normal and the problem is actually obstructive? So for women, if there's a low day 21 progesterone, again, is it central with a low FSH or LH? Is it primary with a high FSH and LH? Or is it something else? Now, there are others, the congenital central and the acquired central, that's like a prolactinoma. And PCOS is sort of a special type of peripheral, which we will discuss. Okay, so here's some data mining. We're doing day 21 progesterone. This is the distribution of progesterone levels we get in the laboratory. I've put it on a log scale and you can see there's 2 clouds of progesterone results. There's one group of women that have progesterones of about 0.5 to 5 and another group of women who have progesterones of about 10 to 100. Now they're not 2 different types of women, they're just the same woman at the different parts of the cycle. On day 21, the progesterone should be high in the luteal phase. So this is the distribution of day 21 progesterone in our laboratory. There are some women with low progesterone, but you can see where the normal range is through that data mining. If we measured progesterone on day 2 or 10, when you haven't ovulated yet, most of the results are in this follicular phase. we might be able to discuss why people. And so here's the results in the follicular phase, so about 0.5 to 5. Now, the last thing is progesterone is also elevated in pregnancy, and it's typically between about 20 and 200. So if we put all those things together, progesterone tells us a lot. It tells us if you're in the follicular phase or the luteal phase, and if it's above about 50, you may be pregnant. Don't forget about pregnancy if the progesterone's over about 40 or 50. Okay, so the first day 21 progesterone we've got, it's a lady with query polycystic ovary syndrome. The day 21 progesterone is 3. It's not elevated. That's the key. So here the progesterone level is not in the luteal range, which suggests an anovulatory cycle associated with PCOS. So it could be just confirming that PCOS can cause anovulatory cycles, or it could be that the period's going to be delayed. We thought it was day 21, but this is going to be a long period, and day 21 is actually equivalent to early in the period. Now, so this is the luteal progesterone. The other thing is that the other hormones also have different levels in the different phases. Estradiol is a little bit higher in the luteal phase than the follicular phase. FSH is a bit higher in the follicular phase than the luteal phase. And LH is pretty much the same in both phases. And just some more data mining. Can we see that? Well, here are the estradiol levels when we see women with high progesterones, and you can see that they're higher. And here are the FSH levels in women with high progesterone levels, and you can see they're lower. And LH, where they're both, it's the same in the luteal and the follicular phase, it's the same. So this is useful because I've actually validated the reference interval in the kit insert using our lab data. Okay, another lady, she's had Clomid, which is something to stimulate ovulation. It's actually interferes with the estrogen feedback and causes a stimulation of ovulation. And so this woman got a progesterone level of 60, very high. Now, we might think that maybe she might be pregnant. Well, she's probably not pregnant yet because the FSH and LH aren't suppressed. They're usually suppressed in pregnancy. And remembering that she had Clomid, she's had like a super ovulation, not just an ordinary ovulation. So we'd expect the progesterone to be higher than it normally would be. So the comment would be the day 20 progesterone level is in the luteal range and consistent with Clomid therapy, and specialist management's noted. Okay, this lady saw a dermatologist for acanthosis nigricans, which is a sort of a darkening, a pigmentation of her skin. And she's also obese. And that's a warning that she might have insulin resistance. And so they were testing her hormone levels, and they found a high testosterone, a low sex hormone binding globulin. Because sex hormone binding globulin binds testosterone, if you've got a low level, you'd have a high free testosterone. And she's also got a high anti-Müllerian hormone level. Now, her cycle is normal, but she's got all these abnormalities in her androgen. So raised free testosterone is also due to the low sex hormone binding globulin. There's a probable elevation of AMH. Now here we've got a comment because not many labs have a reference interval for AMH because usually people under the age of 25 aren't really trying to work out whether they're menopausal. And so we gave the 10th to 90th percentile in 25 years of age, and that's outside the range for later in life. So we've said did a testing for dyslipidemia and glucose intolerance because of this likelihood of PCOS in a woman that's got evidence of hyperinsulinism and obesity. Now, just some words regarding the calculated free testo. We've published a bit in Annals and so on, but there's different formulae for that. The simplest is just the ratio of testosterone to SHB, it's called the FAI. There are other more complicated formulae. The Sottegard, not many people do. It requires a program to go back and forth to get the right value. But the Vermeulen's very common in labs. In women, I wouldn't say that the vermeulin's is much more important than the FAI. Both of them work pretty well in women. In men, it is very important to calculate the vermeulin rather than the FAI. The FAI can be completely misleading. So that woman had a low sex hormone binding globulin. Why did we? Well, the causes of a low SHBG include hyperinsulinemia, hypothyroidism, and anabolic steroids. They're all hormonal causes, really. High SHBG can be the opposite, a lack of insulin, an excess of thyroid hormone, or rather than an excess of testosterone, an excess of estrogen. And the estrogen is also part of the pill and cirrhosis. And in our laboratory, we can show that the women who have globulin or low SHBG are more likely to have high average fasting insulin. So there's some recent guidelines regarding polycystic ovary syndrome. Generally, you need 2 or 3 criteria, either irregular periods, evidence of androgenism, or polycystic ovaries. So that woman that we've discussed, she really only had hyperandrogenism, and she didn't really have, we don't know what her periods were like, or we don't know what her ovaries were like. But there is another aspect to PCOS because it's not only just the androgenism, there's also high insulins, a risk of metabolic disease and cardiovascular risk, which must never be forgotten. So here's her triglycerides, high trigs, low HDL, which is part of the metabolic syndrome. Her fasting insulin is ridiculously high. And her glucose tolerance test shows that even she's a type 2 diabetic, high insulin, but it's not working. And her liver function test shows she's probably got a fatty liver. Yeah, most people with a trig over 1.5 will have a fatty liver. Here's a 16-year-old girl who's got a high sex hormone binding globulin, a high testosterone, but the testosterone level's low. The free testosterone's low. There's so much binding protein that there's hardly any free testosterone. So if those causes of very high SHBG, is she likely to have high or low insulin or high thyroid hormone or high estrogen? Well, we know she's got high estrogen. She's at the 16th week of pregnancy. She's got an estradiol level of 30,000. And generally, so the comment we had, raised testosterone is solely due to the marked increase in SHBG, which may be seen in pregnancy with elevated estrogen. No follow-up is required. And so here's the relationship between sex hormone binding globulin and estradiol. So when in generally around 10 to 13 weeks, when G and estradiol are maximal, you can get these astronomical levels of SHBG. Okay, so this woman, day 21, they've done the hormones. She's got high FSH, LH, low estradiol. That's at the menopausal range. So menopausal level of hormone, possible perimenopause. Consider AMH if repeat testing in 4 to 6 weeks. You're not supposed to have menopause at age 39. It's part of the definition of premature ovarian insufficiency or failure. So it needs to be confirmed quickly. So she's at this stage. She's got incipient ovarian failure. Remember, she had a day 21, so she must be still having periods. And so she's got elevated FSH, but she's having periods. So she's got incipient ovarian failure. If her periods are irregular, she's got transitional ovarian failure. And if she hasn't had period for 4 months, and you confirm the level, then she's got premature ovarian failure. Now the causes, 90% are idiopathic. It's our favourite term in fertility. But there are other causes. So women that have had chemotherapy or radiation can often have premature ovarian failure, autoimmunity, hemochromatosis. And the importance of it is that the earlier you have menopause, the more likely you are to get osteoporosis and premature cardiovascular disease as well. So the investigations you should do, well, make sure that it's not something that we can rule out. The karyotyping, the autoimmunity, do the bone density, because she's going to be in trouble if she's got premature menopause. Okay, another woman. Now she's gone formally through this process. She's wondering whether she's fertile. Day 21 progesterone, unmeasurable. No evidence of ovulation. Consider checking FSH and estradiol. FSH and LH, very high. Menopausal level of FH and LH, possible perimenopause. Consider AMH if repeat testing in 4 to 6 weeks. So she's under the age of 40. We need to try to work out whether she's premature menopause fairly quickly, and I'll tell you why in a minute. Here is her AMH levels. Now, AMH levels are typically within the range, let's say about 10 to 80 in young women and about 5 to 30 in older women. Hers was unmeasurable. She's got an AMH level which shows that there's no developing eggs. Now, why is AMH so useful? AMH is useful because it's falling right through reproductive life. FSH, if we relied on FSH generally doesn't rise until age 40 anyway. So we don't get this early clue of ovarian failure with FSH. We get the early clue with AMH. And some people are interested in IGF-1. I haven't seen that myself. So therefore, AMH has greater sensitivity for premature ovarian failure than FSH. The same specificity, but better sensitivity. Okay, now she's going for assisted reproduction. So the hope, she wanted to get pregnant. She's got the sky high FSH and LH. She's got an AMH of 1. Does that mean she is infertile and she's wasting her money? Well, it doesn't. So here is the pregnancy rate with IVF according to AMH levels. And even with an AMH level that's undetectable, IVS has a 40% success rate within a year or within 1 or 2 years or within 2 years. And really, even if your AMH was healthy, the success rate's about 60%. So AMH of undetectable is 40%, AMH level of 2 is 60%. So the reason is because the AMH is really useful to the IVF doctors to know to give plenty of stimulation. She's got very few eggs. They have to give a lot of stimulation to get, but they do. Okay, so now with menopause, over the age of 40, you don't do any tests. You don't need to do any tests according to the NICE guidelines. If they're age of 40, they've got menopausal symptoms and their periods, they've got menopause. What do you need to do tests for? And they say, do not use these other tests because over the age of 45, they should be negative anyway. If they're between age 40 and 45 and you're trying to work it out, well, then you can do FSH. If they're under the age of 40, do FSH and repeat it in 4 to 6 weeks. And they said do not routinely use anti-Müllerian hormone, but I think it's mainly because it's an expensive test and people didn't understand the importance of it back in 2015. But nowadays, people do, they certainly need it if the doctor's considering IVF. Okay, lastly, a 41-year-old woman. She's older than 40. This is not premature ovarian failure. Here's her hormone. She's got high estradiol, high FSH, LH, low progesterone, estradiol. So this is menopausal level of all hormones consistent with menopause as the cause of her hot flushes. She was having hot flushes. Further investigations are not necessary unless the flushing seems atypical. So it's a bit of a trap. Don't just say it's menopause, because it could be something like a carcinoid syndrome or a FEO. So if somebody's got diarrhea or raging hypertension with their flushing, they might be menopausal, but there might be another cause of their flushing. So just be a little bit careful in just writing off flushing as. Okay, now we're going to finish a bit on men. So men, the FSH drives spermatogenesis, LH drives testosterone production. Here are the FSH levels of adult men. They don't seem to change with age. There's no menopausal. There's no andropause. Okay, there's no andropause there. So FSH is constant in men. LH is constant in men, at least up to the age of 80. Testosterone, maybe it declines slightly with age. Very subtly it declines with age. SHBG does rise slightly with age. We think that's because of obesity and the relative increase in estrogen compared to testosterone. But anyway, slight increase with SHBG. Now, if testosterone is slightly falling with age and SHBG slightly rising with age, it does mean that calculated free testosterone falls with age. What about semen count? What does that do with age? Not much. It doesn't decline with age. It's much like the FSH and LH. It's pretty constant. But when we look at the semen count against LH levels, well, virtually as soon as your LH is above 10, your semen count disappears. So that's not much use. LH isn't much use. As soon as it's over 10, you might be infertile. LH is a little bit more useful because when FSH is a bit more useful. When FSH is above 10 or 15, you still might have a sperm count. So here's a man who's 38 years old. Here's his sperm count. So good volume, but no sperm. Very low sperm count indicates hypogonadism. What sort of hypogonadism is it? Is it primary or secondary? Well, we don't know unless we do these tests. So we've done the tests and FSH and LH are high. Testosterone's mildly low. So this is early primary testicular failure. So you can see the LH is starting to fail, but the FSH usually goes first. In early testicular failure, the FSH usually rises first as the sperm count's falling way before the testosterone falls. Another man, here's his testosterone, and yeah, so his testosterone is 41.8, high testosterone. What the hell does that mean? Why has he got a SHBG, which is 236? Well, he's not pregnant. Is he insulin depleted? What were the other causes? Increased testosterone due to increased calculated free testosterone indicates androgen status is normal. Suggests thyroid function test. Until proven otherwise, this guy's got hypothyroidism. And he does have untreated hypothyroidism. Doesn't have a high testosterone, he has a high thyroid hormone. Here's another man, low levels of FSH, LH, low level of testosterone, and a lowish level of SHBG. Results indicate hypogonadotrophic hypogonadism. And we've said consider the causes of low SHBG, anabolic steroid use, hypothyroidism, or hyperinsulinemia. He actually had central hypothyroidism. So the thyroid hormones are low because he's got hypopituitarism. So this is central hypogonadism and central hypothyroidism. 21-year-old man, low FSH, LH, very low testosterone, and SHBG that's low. Like this is not low. This is extremely low. And so even though the comment is the same, consider anabolic steroid use, hypothyroidism, and insulinemia, This is way below what you'd normally expect in hyperinsulinemia and hypothyroidism. So I'm suspecting anabolic steroid use. And there are some simple tests in the laboratory you can do, which are the HDL. Now, this is not a low HDL. This is a ridiculously low HDL. This confirms anabolic steroid use. I'm happy to tell the doctor the patient's taking anabolic steroids, whether they admit it to you or not. Okay, another, and he's got a raised ALT, perhaps because of his lipids, but the anabolic steroids can be also hepatotoxic. Okay, another man, he's got SHBGF4. This is exogenous testosterone. His sperm count. If you switch off your FSH and LH, you've switched off sperm production. So extreme oligospermia may be due to anabolic steroid use. Suggest checking FSH, LH, and testosterone. They've disappeared. Okay, so in summary, interpretation of hormone levels in fertility requires a knowledge of normal physiology, and that should be reflected in your reference intervals. The fertility issues generally need both the gonadotrophins and the steroid hormones to work out if it's primary, secondary etiology, and usually confirmatory testing of some kind is required, either repeating the gonadotrophins to show that it's a permanent condition, or confirmatory testing by doing associated testing like thyroids or lipids and so on. So that's all I've got. So I think I've left 15 minutes for discussion, which I'm amazed for. Sorry about that, everyone. You've gone through 100 slides. Anyway,
Thank you so
that's my
much.
style.
Yeah. Thank you so much, Professor Ken, for your really very informative and thorough presentation. And so then now we have the Q&A session. I don't see any questions on the chat yet. Does anyone have any questions? Feel free to type on the chat or just unmute yourself and ask your question. Okay, I see a question just come in. How should one interpret isolated raised LH levels in primary infertility?
You would have noticed in some of my cases that LH is particularly difficult because an LH can be a mid-cycle surge. LH rises much more mid-cycle than FSH. And so when you see, if you're testing TAE21 and you see this LH level that seems to be high and no progesterone, it looks like they've got secondary infertility. But it could just be that the period, in women with irregular periods, that the LH level is actually mid-cycle. So be very careful in interpreting the high LH level. The other aspect of LH, which I'm sorry we skimmed past with the polycystic ovary case, is generally it's not really a diagnostic test, but generally in polycystic ovary levels in syndrome, the LH to FSH ratio is quite high, more than about 2.5 or 3 to 1. So it is a sign, a suggestive sign of polycystic ovary syndrome. So that would be my two cautions. One is that if you see a high LH in a woman, well, it might be polycystic ovary syndrome. Check all those other things. Or a high LH level may be a mid-cycle surge in a irregular period. So there was so I generally look at it. I do look at it, but I don't. Nobody uses it as a diagnostic criteria.
So yeah, this kind of ties into the next question as well, which is what is the value of the LH-FSH ratio for PCOS? Is it diagnostic?
Yeah, we've answered that. So nobody uses it as a diagnostic test. There's some things in polycystic ovary which date from 10 or 20 years ago, where we said that the LH-FSH ratio could be high, the DHEA could be high. They were. Nowadays we sort of understand that the free testosterone's high, and the lipids are abnormal. But the LH to FSH ratio is not considered a diagnostic criterion anymore for that.
So it's more an indication.
Yeah. Psychiatrist and prolactin from Sam. Do you want to read?
Oh, yeah. Just for the benefit of those
Yes.
who are not checking the
Yeah.
chat, I'll just read it.
Yes.
Why do psychiatrists measure prolactin in their patients? And what are the effects of a raised prolactin on fertility hormones?
Yeah. So prolactin is often elevated in stress. Prolactin can be elevated with a lot of antidepressants because they interfere with dopamine metabolism. So there are mild elevations of prolactin in psych patients, which are explainable sort of from stress or drugs. But you don't really want to just accept that the high prolactin is explainable because the patient's got infertility. They may have a prolactinoma. So it's a difficult thing, but we generally, as well as looking for macroprolactin, if the prolactin's mildly elevated, 500 to 1,000, we often say, well, that's probably due to stress. Repeat it when she's calmer and see whether it's lower. Even if it's over 1,000, a repeat test, particularly when the patient's rested for 15 minutes before phlebotomy, can be normal. But if a repeat test stays in that range of 1 or 2,000, or certainly if it's over 2,000, which is atypical for stress or drugs, then you must consider whether the patient's got a prolactinoma and don't ignore it because the whole of the pituitary and their eyesight's at stake. So it is a sort of a point of anxiety for psychiatrists to interpret those prolactin levels.
Okay, thank you. We have elaboration from the previous question about we have a case where LH is very high, more than 20, with normal FSH, prolactin, and normal estradiol on day 2. What can we suggest or interpret?
I'm not sure. Day 2, it shouldn't be high. I mean, because it could be high mid-cycle, but day 2 of a normal period wouldn't be high. So the only thing that I would be wondering, whenever it's something unexpected, you'd always look at analytical problems, remembering that some assays do have artifacts, heterophiles or biotin. Before you start, wondering how these impossible results could be real, check that first. Otherwise, it really depends on that FSH level as well. So if the FSH level is high-ish as well, then it may just be that patient's got chronically high. If it's isolated elevation, it's very rare to have LH-producing tumours. So I wouldn't be, in repeat testing, you might see a rise, but I wouldn't be interpreting as an LH-producing tumour unless there was something else to suggest that. I don't know whether that's what you're implying.
Okay. All right, then maybe we can move on to the next question. Do oral contraceptive pills or testosterone medications interfere with immunoassays, and how long should they be stopped before testing?
Good question. So assays, let's say for estradiol, vary in their cross-reactivity. They're all sort of set as, let's say, 100% cross-reactive with estradiol, but their cross-reactivity against ethinyl estradiol, synthetic estradiol, which is in the pill, varies from assay to assay. Some of them will pick it up as if it was native estradiol, and some won't detect it at all. And so doctors are very, and it's sort of something that doctors should avoid doing, monitoring synthetic replacement with assay which was aimed against a natural hormone. You just don't know what you're measuring. And so an our assay with the Roche assay, it doesn't measure ethinyl estradiol at all. And I think the Siemens assay does cross-react significantly. So you'll get quite different results from different labs. Now, it's easier said than done. You need to stop the hormone and remeasure. There's two problems with that. One's the half-life of the drug. It's fairly short. The drug will be gone in 2 or 3 days. But the suppressive effect of the drug might not be gone for weeks. So, so it's awkward because the general rule is you need to stop for a full cycle before you can work out what the natural cycle is, because the synthetic hormones interfered with the natural cycle. With testosterone, same sort of problems can exist. There are some assays that cross-react with synthetics. It's not so much synthetic anabolic steroids. They rarely cross-react, but things like tamoxifen or Livial can cross-react in testosterone assays. So again, you could stop the drug and it'll be gone in 2 or 3 days, but the suppressive effect of the drug may be there for weeks.
I see. So can I just clarify that even if you have an immunoassay that doesn't cross-react, you would still recommend stopping the drug for 1 cycle to get to see the natural?
Yes, you're supposed to have 1 complete normal cycle off the drug before you can work out whether they've gone back to a normal cycle, because that, if you like, the drug has affected the cycle that they're in.
Right.
You need a normal cycle before. That's in women. In men, well, you're probably, it depends on how long they've been on it. And it's the same with the pill. The longer you've been on it, the longer the suppression can last. So, but it's probably at least a month before you can assume that a man might have come back to normal after taking exogenous androgens, at least a month.
Okay. All right. So next question we have, is there any relationship between PCOS and cardiovascular system related diseases? I assume
yes. Well, PCOS does increase your risk of cardiovascular disease because of this issue of insulin resistance and dyslipidemia. So, but PCOS, the good thing about PCOS is it tends to occur at a young age, and usually, because it's a disease of hyperinsulinemia, your islets are still intact. If you can just make that insulin work, you can reverse the resistance and prevent that long-term disease. So, a lot of endocrinologists looking after PCOS patients go very aggressively to try to treat their PCOS so that they don't run into problems with insulin depletion. So, even if they may not be glucose intolerant or diabetic, they're often treated with metformin to decrease the insulin levels immediately. So yes, it is. There are a lot of papers about how important to manage the cardiovascular risk of PCOS.
Okay, thank you. We have 2 questions about different patient populations that are quite interesting.
Yes.
The first one is for transgendered patients or people who underwent gender reassignment surgery. Which gender cutoffs or reference values should we use?
Yeah, so they don't have a gonad that produces estrogen or produces testosterone, so they're usually getting supplemented with exogenous steroids. So if you were going to monitor their exogenous steroid level, well, you better make sure you're using an assay that can measure that exogenous steroid. So, and generally that's even fraught with danger, but you might, because there's no way of using the gonadotrophins really safely to monitor whether they've got an adequate replacement. So it's not something that a GP would do. It'd be only something that a transgender specialist would do. And generally, they use standard doses rather than try to titre the dose against the results from the lab. It's just fraught with danger. I mean, I've had patients who are over-treated because they've measured this exogenous steroid on a system that doesn't respond, and they've kept increasing the dose and ended really low HDLs or other problems. So yeah, I don't think there's a simple answer for that. Just leave it to the specialists, I think.
Thank you. And finally, our last question. Do thalassemia patients have a tendency to have delayed puberty? In our hospital, we have a lot of thalassemia patients with low levels of FSH and LH.
Yeah. Well, I mean, the more profound the anemia, the more likely you are to have delayed puberty. So sickle cells, the classic, they almost all have, well, the significant proportion have delayed puberty because that's quite a severe disease. Yeah, so in thalassemia major, where they're requiring transfusions and everything, well, they're probably going to have delayed disease. Thalassemia minor, which is borderline anemia and microcytosis, I doubt that's associated with delayed puberty. I don't know, but I doubt whether it would be.
Okay. So it's at the end of the hour. We have one last. Okay. So we had a quick clarification that these are thalassemia major patients.
Yeah.
Right. And so the delayed puberty is based on the severity of the anemia.
Yes. It'll be related to the degree of anemia and all of its associated management, the hospitalisation, the transfusions, and all of that.
Okay. So one last question. For pediatric population, any recommended reference ranges source for fertility tests?
That's a good question. Look, generally, I use the kit inserts are usually pretty good. Other than that, Solden is okay. I do, but the problem is with a lot of those things, they're sort of and it's really hard to draw a line. I think the Caliper study had trouble because they'd sort of divided people into 5-year blocks, but people don't suddenly age at age 5 and age 10. They're continually aging. So ideally, what we're heading for is some continuous growth curves for children. And people are starting to collect data, and it really can only be collected, as I've shown, through indirect data mining. Nobody's going to bleed thousands of children to define these reference intervals. But indirect data mining can give us a better feel for what the transition looks like. And so we might actually have reference intervals for each 1 year of age rather than. Now, one last thing there. Age is a surrogate for pubertal development. The proper reference intervals are stage related. And there have been some work by some people to relate. I think the Mayo Clinic site has a lot of hormones according to Tanner stage. What you need to be careful of is those intervals are defined with a particular assay. So you need to be sure that whatever assay they were defined with, your assay is comparable to that assay. So yeah, probably overall, we have used a lot of the Mayo Clinic Tanner stage reference intervals as a guide to whether and those intervals you can't express as a reference range on the report because you don't know the Tanner stage of the child. They have to be represented as a table at the bottom of the report.
I see. Okay. Yeah, thank you for your inputs. Since there are no further questions and we're at the end of our time, thank you so much again to Professor Sikaris for your wonderful presentation and for sharing all your knowledge. And just to say that there will be a feedback form again that will be sent to you. And if you need the certificate of attendance in particular, please do fill out our feedback form. Our next session is going to be, we'll have Dr. Sam again for a continuation of endocrinology. and parathyroid disorders on January 13th. So do look out for that email showing you where to register. Thank you very much for your participation, and we hope to see you at the next webinar. Thank you so much, and have a